Support for the Disability Rights and Resource Summit is made possible by Virginia Housing, our presenting sponsor, Comcast, Dominion Energy, Miles and Stockbridge, and many others.
I'm here again to talk about some of the changes that we're going to see to Medicaid in the upcoming 1 to 5 years, most of which are going into effect because of the big budget reconciliation bill that Congress passed and the president signed this summer. I'll also touch very briefly on just a couple of changes to the marketplace and to Medicare, since these changes very much wrap around what the bill also accomplishes with Medicaid. So like I said, there are a couple of different sources of healthcare changes that we're going to see over the next few years. We have the Budget Reconciliation Bill, or the One Big Beautiful Bill Act. For the sake of being quick, I'm going to refer to it throughout the presentation as OBA, that was signed into law in the summer. The Centers for Medicare and Medicaid also published a rule this summer that is making changes to the marketplace. And of course, if you're following the news, you may have heard that enhanced subsidies for the marketplace are expiring at the end of this year, which will make marketplace insurance more expensive for many folks. We'll mostly focus on those OBA changes, but I'll touch on some of the other changes as well very briefly. So one of the things to explain about all these changes is one of the things that is so complicated about understanding them, about keeping track of them, about doing advocacy around them, is every provision, and there are dozens, has its own implementation date. We have a couple that have already gone into effect at the end of the summer, and we have some that actually won't even go into effect until between 2028 and 2030. There are really too many provisions for me to cover absolutely everything today. So I pulled out the ones that are most important, and I pulled out the ones that affect Virginia. There are some provisions in there that won't affect Virginia at all. I do have, because we can't cover everything today, I do have a resource slide at the end with extra resources if you'd like to look at them, and that will be completely comprehensive. So before we start off and get launched into all these very nitty-gritty details, I did want to sort of give an overview about what this reconciliation bill accomplishes. It's a cut. It's a really big cut. These are going to be cuts to Medicaid eligibility, to some of the richness of Medicaid benefits, and very importantly, to Medicaid funding from the federal government. And the way it accomplishes this is it very much restricts immigrant eligibility for all public health programs. It introduces really high paperwork burdens for Medicaid applicants. So, just a lot of red tape in there that's going to make it harder for folks to get covered and keep covered. It'll make market plans less affordable. It'll really reduce federal Medicaid funding. It'll loosen some financial protections. So, it's really all one big cut. Um, I do want to also lead off and give an overview of how these OBA changes are going to affect Medicaid disability programs. And as a spoiler, nothing in this bill directly cuts Medicaid disability programs, such as long-term supports and services, you'll hear me call it LTSS, um, or age blind and disabled, ABD. So all of this, of course, includes just full benefits Medicaid, it includes Medicaid waivers, but that doesn't mean that this bill does not affect these programs indirectly. The funding cuts and the eligibility restrictions and all this increased paperwork, red tape burden are really focused on two programs, or two areas. First is that Medicaid expansion. This is the program, Medicaid program for non-pregnant adults age 19 through 64 that don't formally have a disability, formally. This program was, introduced by the ACA in 2013. This program really has a target on its back with this bill, and a lot of the changes really focus on the Medicaid expansion population. A lot of the cuts and eligibility restrictions also really focus on immigrants. Non-citizens are losing coverage in a really, really, really big way. So I do want to first off note that a lot of individuals with disabilities may be enrolled in that Medicaid expansion program. Maybe they just got SSDI, maybe they don't have a documented disability with the government. And these enrollees are going to face some of these big new changes to Medicaid, like the work reporting requirements, where folks have to show that they're employed or meet an exemption to keep their Medicaid. So again, some of the secondary effects that we're going to see on disability programs. The first and the most explicit one is really targets immigrants. A good number of non-citizens who are lawfully present are going to lose their full benefits Medicaid. That could be Medicaid waivers, age blind and disabled, Medicaid expansion. This bill newly excludes them from Medicaid coverage. There's also, like I'd already mentioned, this big new red tape burden where it's just going to be a whole lot of paperwork and a whole lot of navigating bureaucracy for people to get Medicaid expansion for adults and to keep that Medicaid expansion. One of the secondary effects of this is going to strain Medicaid caseworkers and it's going to strain public benefits offices. And of course, those same caseworkers and offices are the people that also process applications for Medicaid disability programs. So there's sort of a secondary effect where we're going to have really overworked staff, and that will make it harder for anybody to get any kind of Medicaid coverage or get it renewed. Another big secondary effect, and this is really for everybody in the state, is those Medicaid funding cuts are going to harm hospitals, especially rural hospitals. It's just going to be a lot less money funneled into those hospitals. And obviously, absolutely everybody in the state gets care there, regardless of where they have their insurance, right? And then one of the really big ones as well that we have to mention is this bill is going to create budget shortfalls for all states because it's going to reduce federal Medicaid funding, which is a big source of federal money that flows into state governments. We'll review some of the details at the end. But what's important to know again is that every state is going to be facing a budget shortfall because of this. And states are all going to have to figure out how to make up for that shortfall. In the base case scenario, and the one, of course, many people will be advocating for, is that Virginia raises new revenue to continue funding Medicaid. And particularly, we have Medicaid waivers in mind for this. Because Medicaid waivers are an optional Medicaid program. States don't have to have them. They have Medicaid waivers at their discretion. Other programs are also optional, like adult dental, school-based services are also an optional Medicaid program. But Medicaid waivers are the most expensive optional program that Virginia has, as is true in many states. So again, in order for the state to make up for the shortfall, they'll have to raise revenue or they will have to make cuts somewhere. At this point, we're very early in the process. No states have made any final decisions about what they'll do. Obviously, those are legislative decisions that states, legislative and executive branch decisions, states will have to make over the next couple of years. So we don't really have any more information than this, other than, of course, there are many advocates that are preparing to ask states to raise revenue through various mechanisms. So with that said, we'll start reviewing some of these changes. I've organized everything by year because, like I said, these changes all phase in different years. So the first change we're going to see is one of these big immigrant exclusions. Right now, there are a limited number of immigrants that are able to get full coverage Medicaid as adults that are not pregnant. So that's going to include, right now, you have refugees and asylees, lawful permanent residents, you usually hear them called green card holders, Ukrainian and Afghan parolees, victims of trafficking, Cuban Haitian entrants, a few more humanitarian statuses as well. All of these folks are eligible for full benefits Medicaid. However, starting in October of 2026, the OBA bill will hugely cut down on that list of immigrants that qualify. In about a year, the only immigrants that will continue to qualify for full benefits Medicaid as adults that are not pregnant will be lawful permanent residents, so your green card holders, COFA migrants. These are folks that are citizens of Micronesia, Palau, and the Marshall Islands. They mostly live in Washington State and Oregon, don't really have a lot of them in Virginia, and also Cuban Haitian entrants. Those three groups of immigrants will be able to keep Medicaid. Everybody else is excluded. This will affect immigrants who are enrolled in Medicaid waivers, in long-term care, and in age-blind and disabled Medicaid, unfortunately. Um, the only kind of good news here is that this big immigration exclusion only applies to adult Medicaid. For non-pregnant people, children and pregnant people will continue to qualify for the same coverage. There is no cut to immigrant eligibility for kids and for pregnant people. The next big one is also something that targets immigrant coverage, although this is really a funding target, and it doesn't really affect eligibility. So this is a provision where federal funds for emergency Medicaid will get cut. For anybody that's not familiar with emergency Medicaid, it's a limited Medicaid program where immigrants who are either undocumented or they have a more temporary status, like a visa holder, temporary protected status, um, they're not able to qualify for full Medicaid because of that immigration status, but they can get emergency Medicaid to pay for some of their emergency care. Right now, the federal government pays 90% of those costs for expansion adults, non-citizens. Starting also in October of 2026, the federal government is going to hugely cut down on how much it pays for that emergency Medicaid. That doesn't mean that immigrants are actually going to be losing this coverage, but it does mean that Virginia is going to have to shift more of its state funds to cover those services, and it's going to be another strain on the state budget. The next change we have coming is one of our first kind of red tape paperwork changes. Right now, people on Medicaid have to renew it every year. Starting at the very end, the last day of 2026, adults in that expansion category, so 19 to 64, not on Medicare, are going to have to renew their Medicaid every 6 months instead of every 12 months. It's just a lot of paperwork, and we're going to see a lot of people lose coverage just because they can't keep up with that much paperwork. This doesn't directly impact Medicaid waivers, long-term care, or age-blind and disabled recipients. Those programs are left out, but again, of course, many individuals living with disabilities are in this Medicaid expansion program. The next change that'll happen also at the very end of 2026 is going to be Medicaid work reporting requirements. If you have heard anything about some of the changes to Medicaid, you might have heard about this. Work reporting requirements are where somebody that has a public benefit, like Medicaid or SNAP, has to show that they're employed or meets an exemption in order to get those benefits. Right now, Virginia and most states have no work reporting requirements. At the end of 2026, that will change. The difference is that expansion adults, so again, people 19 to 64, not on Medicare, are going to have to demonstrate that they work at least 80 hours a month, or that they make at least $580 a month, or that they participate in a work program for at least 80 hours a month, or they volunteer for that same amount of time in order to qualify for Medicaid. There are a few other routes. You can show that you're in school at least part-time. There's some exemptions, like having a dependent child under 14, being a fully disabled veteran, um, being Native American, if you're participating in a substance use disorder program, if you're considered medically frail. And the definition of medically frail has not yet been defined in regulation by the Centers for Medicaid and Medicare. So everybody is sort of anxiously waiting to see what that's going to look like. Um, all of those are going to be exemptions, and those folks will not have to show employment to get or keep Medicaid. There will also be some optional exemptions that states can opt into, like living in a county with a federally declared emergency or living in a county with really high unemployment rates. But the end result of this is going to be that these expansion adults are going to have a huge paperwork burden in order to get and keep Medicaid. It's just going to be this kind of bureaucratic maze that people are going to have to navigate. It's going to be a lot of paperwork to turn in. And so we've seen there are a couple of states that have these, Arkansas and Georgia. And so we've seen what happens when these reporting requirements go into effect. And that is pretty clearly that people lose Medicaid, not because they don't meet the new requirements, but because they just can't handle the paperwork. So we're going to see a big loss of coverage because of this. Again, this doesn't directly impact long-term care, Medicaid waiver, or age-blind and disabled recipients, um, but it will really strain the local departments of social services. And so people in those other Medicaid programs might see the effect on their caseworkers who just can't act quickly. So definitely a risk for secondary effects. So that's what's coming next year, but we also have some changes coming in 2027 that will be quite significant. The first one is a reduction to the Medicaid retroactive period. So right now, folks can apply for Medicaid and they can actually receive up to 3 months of retroactive coverage. So if you apply today, you could actually get coverage as early as August if you meet all the program qualifications from August onward. That really helps people that maybe had an unexpected hospitalization, an unexpected surgery. Um, but unfortunately, the OBA bill is going to reduce that retroactive period. So expansion adults will only get 1 month of retroactive coverage. All other categories of coverage, Medicaid for kids, Medicaid for pregnant people, age blind and disabled Medicaid can get up to 2 months of retroactive coverage. Um, so obviously this isn't great because this retroactive coverage really helps people with unpaid bills from unexpected medical services. And this will be going to affect the very first day of 2027. The second change is, I think, the only marketplace change I'm really going to talk about. And I wanted to include this because it really wraps around the Medicaid exclusion of immigrants. The marketplace is doing the same thing. So right now, almost any lawfully present immigrant is able to get marketplace plans with the subsidies that make the plans affordable. Um, However, January 1 of 2027, that's going to change and there's going to be this huge exclusion. Instead of some people with almost any status being eligible for the marketplace, temporary protected status, special immigrant juvenile, visas, all kinds of stuff, it's going to again winnow down to just 3 statuses. That's going to be just like Medicaid, your green card holders, the COFA migrants, and the Cuban and Haitian entrants. So many immigrants will lose coverage, or they'll be barred by coverage from the really high prices of unsubsidized marketplace plans. So you can see already, immigrants got cut out of Medicaid, now they're getting cut out of the marketplace. So 2 really big public health programs. Medicare, this change will go into effect January 4th of 2027. The same thing with Medicare to exclude non-citizens as we've seen with Medicaid and the marketplace. Right now, a lot of lawfully present immigrants who have worked for 10 years in the United States and paid those Medicare taxes can get Medicare. They've paid into it, right? Unfortunately, also starting in the beginning of 2027, the federal government is going to exclude immigrants from Medicare unless they are green card holders, COFA migrants, and Cuban Haitian entrants. We're concerned about all of the exclusions of immigrants from public health programs. I think Medicare may be the most perturbing. First of all, because if folks are elderly, they're much less likely to end up having employer-based health coverage. And also because, again, these individuals have paid into Medicare for at least 10 years. They've been taxed for it. And this will not only prevent immigrants from enrolling in Medicare, it will also disenroll folks that are currently in the program. 2028 changes. A big 2028 change is right now Medicaid doesn't have cost sharing. People enrolled in Medicaid don't have to pay anything when they go to the doctor. They don't pay a monthly premium. They don't pay a copay. They don't pay co-insurance. It's free coverage. This new rule, starting in January of 2028, will institute copays for expansion adults. Again, the folks 19 through 64, not on Medicare. Um, there will be some exceptions to these copays. These adults won't have to pay the copays for primary care, for mental health care, substance use disorder treatments. They'll have to pay a very small nominal price for prescription drugs. However, um, Virginia did used to have something like cost sharing, and so we know what the effect of this is going to be. In the past, when Medicaid members had to pay copays, a lot of people ended up losing coverage because they didn't pay a copay, they didn't pay a copay on time. They paid the copay, but the provider just never let the Medicaid agency know. And so this led to a lot of Medicaid members losing coverage. And then because they still met all the income requirements, applying again right afterwards. We call this churn, where people go on and off Medicaid coverage constantly. It's not good for anybody. It creates a lot of coverage disruptions for the people that, need medical insurance. It creates a lot of work for those local Department of Social Services offices. And again, more work for those departments of social services offices means that they have less time to handle cases, and that affects everybody with Medicaid in all programs. So this is another one that I would sort of characterize as being part of the red tape. There's a change here for Medicaid. For one of the only ones that specifically targets long-term care is a cap on home equity limits. So right now, when states evaluate folks for long-term care Medicaid, to be in a nursing facility, states have limits on equity. And the federal rules that equity has to be in between 730,000 or 1,097,000. And that is actually updated annually for inflation. So it goes up a little bit every year. The new rule is going to cap that evaluation at 1 million for homes, um, regardless of inflation. So this is probably not going to have as much of an impact today, but in the upcoming decades, it could deny long-term care to seniors that bought homes many, many years ago, and those homes have really appreciated in value. That implementation date will be January of 2028. Now we've gotten to some of the most kind of complicated, policy-dense ones. This is a reduction of provider taxes. A lot of the changes we've seen before have really been a change to eligibility or, more burden in order to enroll. This is just a straight funding cut. So a little complicated, but how it works right now is Medicaid is a joint federal and state program. The federal government pays the bulk of costs, but states kick some in. And the more money that states contribute to their Medicaid programs, the more the federal government matches that. So the federal government incentivizes states to contribute more, and then the feds throw in more as well. One of the ways that states help finance their part of Medicaid funding is by taxing medical providers. So this can include taxing nursing homes, it can include taxing hospitals, it can include taxing managed care organizations, which are the health carriers, the health insurance companies that provide Medicaid care, kind of your normal suspects like Anthem. And so this is how states raise a lot of their Medicaid dollars. Virginia right now does not have a nursing home tax, does not have a managed care organization tax. We do have a decent hospital tax. We currently tax hospitals at 6% of their patient revenue. But unfortunately, starting in 2028, the federal government is going to start reducing the rates at which states can tax those providers to raise those Medicaid funds. So starting in 2028, it'll reduce that tax rate by 0.5%, until the limit reaches 3.5%. So the result of this is essentially states have less money to put into their Medicaid programs. Because states put less money into their Medicaid programs, it also means the federal government doesn't match as much. So the federal government response actually reduces its Medicaid payments to states. So this is really a double financial hit for states and for Medicaid programs. It's also already affected Virginia because we had another sort of hospital tax that we were going to put into effect this year, and now we could not. Um, Another change that's really kind of technical and is not directly an eligibility cut is a cut to state-directed payments. The bottom line of this is it is going to hurt hospitals. And obviously hospitals are where all of us get care. So we currently, a state-directed payment, one of the problems with Medicaid and providers is that providers have not always wanted to accept Medicaid at their practices because Medicaid doesn't pay as much as commercial insurance. States realized this was a problem several years ago. And they passed rules so that states can actually increase some of the money that they pay to providers to incentivize providers to accept Medicaid and also to keep, more rural hospitals and rural providers, floating. So right now, Virginia currently has one of these state-directed payments, one of these kind of enhanced Medicaid payments, where we reimburse hospitals for Medicaid services at a higher rate than normal. We reimburse hospitals for Medicaid services at a rate that really looks more like what a commercial insurer would pay. So even higher than what Medicare pays. This really helps keep our hospitals functioning, again, especially in the rural areas of the state, and we have a lot of rural areas in the state. This new rule is going to limit those Medicaid reimbursement rates. It actually steps down those reimbursement rates until it's at 100% of the Medicare reimbursement rate. The bottom line is that Virginia is going to be paying hospitals less for Medicaid services, and this will hurt hospitals. We do have just a couple of smaller changes that I'm going to review really quickly. Um, the the first one is changes to error payments. So right now, if states make a lot of mistakes when they're giving Medicaid to people, if they, give Medicaid to a bunch of people that weren't actually eligible, or if they pay too much for people's medical care accidentally, the federal government can go after the state and ask for some repayment of federal funds. The new rule makes it easier for the federal government to do that. And the result here, and this could be a secondary effect to Medicaid waivers, to age blind and disabled, to long-term care, is that it's going to incentivize Medicaid agencies to be more aggressive in denying coverage or in terminating coverage. Because they're really incentivized to not have people in coverage that might not be eligible. So this just could make it harder for everybody to get Medicaid because caseworkers could get really intense about, prove your income, prove your immigration status, right? So a secondary effect for folks on the Medicaid disability programs, but they're regardless. It doesn't go into effect for quite a while. This is actually implemented in October of 2029. So states also have some time to figure out how to maybe hire more caseworkers and make their eligibility systems better. There are some other small changes here. I won't review all of them because some of them are really very technical. One of the ones I did want to highlight is the nursing home staffing rule. The Biden administration had previously set a rule trying to sort of raise staffing levels for nursing home facilities. So you would have more staff, so that the staff to resident ratio was more favorable. This new OBA law prevents that implementation until 2034. So that's going to keep nursing homes from being staffed quite as well as they would have been. The other thing, there is something that explicitly allows states to establish 1915 home care and community-based service waivers. Obviously, Virginia already has waivers, so this doesn't hugely affect Virginia, but this is one of the only provisions in the OBA bill that actually will increase Medicaid spending slightly. It's one of the only things we're not worried about. Um, and all the other requirements are really kind of more bureaucracy for providers to navigate and more bureaucracy for state agencies to have to navigate. So if anybody wants more resources, again, I only went over, I think, some of the most important changes that impact Virginia the most. If you would like to look at absolutely everything, I have resources here for you, and you're welcome to check them out. A reminder that Virginia is an expansion state. We do cover those adults from 19 to 64, so there are several provisions in there that only affect non-expansion states. They will never apply to Virginia. Um, but there's some good stuff in here about the work reporting requirements. There's a presentation if you're interested in some of the marketplace changes. There are presentations on that as well. And I think that's all that I had today. I was much faster than I'd realized.
Yeah, that was great, Eleanor. So I'll give folks a chance to reflect, and you can put your questions in the chat. And maybe while we give folks a minute for that, I will take moderator's privilege and ask Eleanor if you've seen yet any responses coming out of the state of Virginia. Has the government kind of started making plans, or is it still too early?
So, from a formal perspective, it is largely too early. They have made formal moves on SNAP programs because those changes are coming earlier, where they are shifting more state funds to cover some of those SNAP services. I can say from an informal standpoint, I think Virginia's Medicaid agency is very committed to trying to keep as many people covered as possible. So there are a lot of implementation decisions that states are going to be making when it comes to things like the work requirements. For example, if you're evaluating somebody for work requirements, are you going to look and see if they've worked all last 3 months, or are you going to just look 1 month back? So there are a lot of decisions state agencies can make to sort of make the work requirements and some of these other paperwork, red tape provisions a little friendlier. And our state agency has certainly signaled informally that they are interested in making everything as easy as possible. Only looking 1 month back, um, trying to add some system upgrades to make it easier for folks to get through the work reporting requirements, adopting every exemption to the work reporting requirements as is possible, like saying, yes, we would like to make it so that people that live in counties with very high unemployment rates don't have to deal with the work requirements. They're exempt. So I do think our state agency is as responsible about this as a state agency could be within the constraints of course, this federal bill.
That's really great to hear. Thank you.
Absolutely.
All right. Any additional questions?
I have a question. I'm not even sure exactly how to word this, but like for example, in the county I live in, they stay already behind on Medicaid reviews. For example, I had one like maybe in May, let's just hypothetically say it was May, and I just got a renewal on the person again, and I contacted social services, and they said, "Oh, that was for the last renewal. He was actually due last November, but they just sent it to me, you know what I mean, in May. So I renewed him then, and then now this is his normal yearly renewal, if that makes sense." And so
Yep.
I'm just wondering what kind of provision is going to be in place, like if they are behind and they don't have the staffing, because we all know how you know limited all the state agencies are as far as community services boards, Department of Social Services, that sort of thing. They're continually hiring, have a lot of turnover, things like that. And so I'm just curious, if they are behind, will people's Medicaid stay in place? Because I'm assuming now that it seems like it does stay in place. or will it be denied? You know, it stays in place because it's their, you know what I mean? It's because of them. But if it were because, like you said, because of the individual not keeping up their paperwork, that's a whole different ballgame. But as far as what kind of provisions in place if they are behind, and you know they're not renewing it and they're not giving an answer, will they keep it active or will it just end on the date that is due for renewal?
Yeah, those are great questions, and I think there are almost sort of three different pieces to parse out there.
Right.
So I think for the first question, if a state agency, if one of the local departments of social services can't get around to issuing a renewal packet or can't process a renewal packet in a timely way, they legally cannot terminate somebody's Medicaid. Somebody has to be given an opportunity to renew. They have to be given an opportunity to submit documents, and the caseworker has to process it in order
It'll
for that
stay
to.
the same then, basically.
Yeah, there's
Okay.
no legal way to get around federal rules to make that be
Okay.
different.
Okay. Awesome. Thank
So
you.
that is the good news. I started with the good news. I'm now going to go into the bad news. The bad news is that you're right. As I think so many people in this call already know, our caseworkers and the departments of social services are already underpaid, overworked, understaffed, retention issues. And so it's already hard to get a Medicaid application through. And that's just going to get worse. So we are going to see a lot of people apply for Medicaid, and it's going to take forever for them to get those benefits because they just don't have the staffing. You're also right where, it's going to be a lot more work for those expansion adults to get and keep Medicaid with the work reporting requirements. It's going to make a lot of people lose coverage even though they're eligible for it. So these are things that we have continued to raise up, I think, to both state legislators and to our federal delegation here in Virginia, particularly sort of hammering away at, hey, our Department of Social Services is already really overwhelmed. They cannot do all of this with their current capacity. They just can't. I think that's a really valuable message for lawmakers at a state or federal level to keep hearing and to keep hearing specifically how it affects their districts. And it's one that we've been raising for almost a year now pretty consistently. And I think constituent anecdotes can be really helpful for lawmakers in these situations.
That's such a great point, Eleanor. Can I ask you to elaborate just on that a little bit? Are there, if folks are interested in speaking to their lawmaker or doing advocacy around this, should they reach out to your organization or are there other groups that are doing this? What are some suggestions?
Yeah, that's a great question. So if you're interested in advocacy, we definitely are advocates and do have lobbyists. We generally are not a grassroots organization where we organize people to, go into a state capitol or to the federal capitol. What we can do is if somebody has stories about how important Medicaid is to them, how difficult it can be to get Medicaid, we can always sort of take those stories down and then, if we have your permission to do so, take them to lawmakers kind of in a batched way, right? We have 80 cases from Richmond City um, or Prince William County, or we can use some of those stories in our media work. I would say if folks are interested in sort of doing more grassroots roots work and sort of, going in person to talk to the legislators. Virginia Organizing is a fabulous organization that does a lot of that work, and they would be great people to connect to.
Awesome. Thank you, Danielle, for your question. And thank you, Eleanor, for letting me add to the question as well. Do we have other questions? We still have a few more minutes.
I think it's just truly, this is Danielle again. I think it's just truly amazing to think about the, I mean, just what a huge issue this is because trying to determine how many more, let's just say, eligibility workers you're going to need to approve people every 6 months, for example, and what kind of infrastructure you're going to have to house all these new staff you need, and all the salaries that are going to be increased because you're having to have more people to renew so much more frequently. So it is just the enormity is unbelievable, you know.
Yep,
It's overwhelming.
absolutely. Yep, absolutely. And again, this is something we very much brought up. as we did a little bit of federal work this last year. And I
Well,
think
thank
it's
you all for
important.
your work.
Thank you. And I think it's important to keep those stories going. I think, we want state legislators to hear that, because state legislators, if they're more concerned about, this amount of work and how it's going to affect people, are going to be more likely to look at something like raising revenue for Medicaid. There are also, federal lawmakers that I think need to keep hearing this even post vote. Um, so. Yeah, that's definitely something that many people, Medicaid recipients, many different organizations that work with Medicaid recipients can be beating the drum on.